the artist. Now, this was a 40-year-old patient of mine who was a typical patient who had all the risk factors that you can only imagine. He was obese, he had diabetes, he was a smoker, a pretty heavy smoker as well, and he also had hypertension. He was neglecting his problems for many years, and he was an artist. Actually, he was an artist who had a little theater in Vienna where he had performances going, and he himself was also on the stage. Now, during one of these performances, all of a sudden he had this abdominal pain and dyspnea, and was admitted to a hospital. And at the hospital, oops, let me just go back, otherwise I'm going to give away what the answer is. So he went to the hospital, and he got all sorts of treatment for abdominal pain, and they even gave him diuretics, and they did an ECG, but nothing really came out of it. But I'll show you the images that I made, because he was dismissed from the hospital, a bit better, but still with dyspnea and pain. And he arrived at my office, actually, with still the same complaints, and wanted to know what the problem could be. So those are the images. What I'm going to do is I'm going to show you these images now with not much comments, and then I'm going to ask you a question. Okay, so take a look at these images again. This is a parasternal long axis view with the aortic valve, which is maybe a bit calcified, but certainly opening well. The mitral valve. And also keep in mind which problems the patient has, namely abdominal pain and dyspnea. This is mitral regurgitation. Maybe think for yourself if this could explain his problems or not. Let me go to the apical views just to show you the patient does have hypertension because he has a septal thickness of over 14 millimeters. Now here's the size of the atria. And this is his 4-chamber view. Okay, let me just see if I can magnify this a bit so you get a better appreciation. Okay. Okay, we found he has left ventricular hypertrophy, but just to give that away, you will have to look at left ventricular function, because possibly something is wrong there. Okay, this is a 2-chamber view. This one is probably better. Let me just increase the gain a bit. Okay, so you can nicely see the anterior wall and the inferior wall. Look at the different segments of the myocardium. And also at global left ventricular function. Again, another 2-chamber view. He was pretty obese, so it wasn't very easy to image. It was difficult to get the anterior wall here, but I think you can appreciate the motion of the anterior wall here as well, right here. Now let's go to the apical long axis view. This is the anterior septum, the posterolateral wall. The patient has annular calcification, not much, but still he's only 48, so you can imagine that the patient has a number of risk factors, because obviously annular calcification is often associated with coronary artery disease. So keep that in mind as well. Okay, another 4-chamber view. Oops. Okay. Okay, I hope you now all were able to look at left ventricular function and at regional wall motion abnormalities, because now I'm going to ask you a question. The question is, right here, I hope on your screen, what is the problem? Okay, what you have to do now is you have to just click on the answer that you think is correct. I can see the answers coming in. I'll give you a few minutes to answer. Ischemia. So basically the question is, does the patient have coronary artery disease, or does the patient have dilated cardiomyopathy? And if the patient has coronary artery disease, which vessels do you think really have a problem? Okay. I can see most of you have now voted. I will close the vote in a few seconds. So if you still want to vote, now is the last chance you have. Okay. So The result is most of you think that there is an inferior myocardial infarction, or at least an inferior ischemia. A lot of you also think that the patient has multivessel disease, so in other words, 2 or 3 vessel disease. Some think that the ischemia is in the anterior wall, and only a few think that it is cardiomyopathy. Well, this just shows you how difficult it is to really make the diagnosis, and I must honestly say I wasn't quite sure where the problem really is. I'll show you first of all what I thought when I saw these images. Well, this segment here for me looked quite suspicious. You see that there is not much wall motion here in the basal inferior septum, so I was actually thinking it must be something that has to do with the right hook coronary artery, or is probably a problem of the inferior wall. But then again, if you also look at the anterior wall, it doesn't seem that the wall motion is normal here in the anterior region as well. And then look at the motion here. There seems to be a hinge point. Maybe the apex has a problem as well. Okay. Oh, you're not seeing this. Let me just hide this. Sorry, you're not seeing this. Okay, let me go back again. It was my mistake. I forgot to turn off the poll. But let me go back to what I just said previously. First, I thought that the inferior wall right here has a problem. But then, looking closely, I saw that there's also a hinge point here, which means that this part of the myocardium seems to have a contraction abnormality. And if you look at the apical 4-chamber view, again, the distal septum and the anterior wall seems to have some form of myocardial dysfunction. Okay, now let me go to the result of the coronary angiography, because obviously the patient needs coronary angiography, and let me show you what we found. So this is the result. Right here, what you see is the left coronary artery. This is the main stem dividing into the circumflex and the RCA, and if you look at the coronary arteries here, you see that there is a large or a very significant stenosis in the LAD. See, this is a very significant stenosis, but there's also another stenosis. If you look more closely, you can see that the circumflex has a stenosis here as well. So one thing is for sure, the patient has multivessel disease, and the LAD is involved, and the circumflex is involved. Now, what about the right coronary artery? Okay. Surprise, surprise. There is no abnormality here. Now, one thing you should also know is if you have a normal coronary artery, it does not always necessarily mean that there is not some form of problem in this vessel, because it could have been that the vessel was reopened. But in this instant, I think one is clear. The culprit lesion is the LAD and the circumflex artery. Now let me go back to the images again, to the echo images, and show you one thing that the users that were with me the last time already know, which is a technique we call speckle tracking, which allows us to look at longitudinal function. I showed you that longitudinal function can be looked in a global way, but you can also look at it in the different segments and see how the regional wall motion is with respect to longitudinal function. Here we have the apical regions, the midventricular regions, and the basal regions. This would be anterior septum, posterior, inferior septal, anterior, and lateral. And blue or pink or lighter shades of red would denote areas where we do not have normal contraction. Now, if you look at this, this is pretty amazing, because this is exactly what we see in the coronary angiogram. So we have the anterior wall, the basal and mid segments, but also the apical segments, the lateral wall, and the anterior septum. And as a matter of fact, the inferior wall looks quite normal, except for the apical region, but that is LAD territory, I would say. So in conclusion, what can we say from this case? Well, first of all, the patient has coronary artery disease, and the patient needs obviously some treatment in this direction, and the abdominal pain is probably something that has to do with ischemia and not with some form of gastritis or whatever. So that was the first information we got from the echo. And the second is that it is not so easy really to look at regional wall motion abnormalities. For example, we were tricked into believing that the inferior wall was not normal. Especially the region of the inferior wall is often very difficult to interpret. So take that under consideration. And then we have to look very, very closely also at the anterior wall and look at the regions, especially at things like hinge points, thickness of the myocardium, and move the transducer in all directions to really get an eye on these regional wall motion abnormalities. So this was certainly a very difficult case, but I think a case which very nicely illustrates that regional wall motion abnormalities are very difficult to interpret. One more thing, maybe a question that I would like to ask to the audience. How do you think the patient is doing at this point? Remember, he had dyspnea. Would you say that left ventricular function is reduced? Does that really explain his dyspnea? Well, left ventricular function is reduced, I would say maybe mildly reduced, certainly not more. And the question now is, does this mild reduction in left ventricular function really explain his symptoms? I want to show you one thing that answers this question. This is the spectrum across the mitral valve. What you have here is you have a typical restrictive filling pattern, which means we have a very high E wave and a very small, almost non-existent A wave. E wave, A wave. So the A wave is probably, or the E wave is probably 4 or 5 times as large as the A wave. So what you can do with this signal is you can look at the left ventricular filling pressure, and you can do the tissue Doppler at the base of the mitral valve. And what you can do then is you can look at the ratio between the E and the E prime. Now the ratio would be, going back to this, 1.23 divided by the maximum velocity of the E prime, which is 0.07, which is somewhere in the range of maybe 17. And normal values would be up to 15 or 12 to 15. So if you are above 15, you can be sure that left ventricular filling pressure is elevated. So what does this illustrate? It just shows us that truly the patient must have dyspnea due to left ventricular dysfunction. So a very nice thing that you can always use, or diastolic function can always be used to look at how the patient is really feeling and how he's doing. With respect to the question that Emmanuel asked, if a tissue Doppler can also be used to look at the wall segments, well, yes, actually you can. It is more cumbersome because you would have to place a tissue Doppler sample volume into the different parts of the myocardium and look at how high the peak velocity is, and you can then determine if a segment has a reduced contractility, and you can also look at other things like post-systolic thickening. It could be done. But the nice thing about the speckle tracking certainly is that it is much, much easier. You can just do that with a few clicks. You get this bullseye display, and then you know exactly what is wrong. Okay, Alan asks if it is difficult to obtain such a good eyeball strain, good bullseye strain if you have poor image quality. Well, as a matter of fact, it's fairly robust, I would say, and even in image quality, which is not so good, you do get such bullseye displays. However, I would be very cautious to interpret such bullseyes if they come from patients with image quality which is not so good, because in reality it is a bit of a black box, and it is still in a way experimental, and there are certain limitations to it. So I personally only use it if I'm sure that the tracking algorithm was good and that I know that some wall is there that can be interpreted. So in this patient, I would say it's a bit of a borderline already, because the image quality, going back to this image here, is not so good. But nevertheless, it does work in this patient quite well, and in reality you can use it in many, many patients.